All right. Well, thank you very much to Seattle Science Foundation on behalf of the University of Arkansas for Medical Sciences. I'm honored to join both the folks at SSF and, as always, our hosts from TBI, from the Texas Back Institute. Thank you, and we're honored for you inviting us to join you on this interesting spine case discussion. Our theme or topic for tonight is central cord syndrome, central cord injury, management and future directions. It is a rather important topic. It is the most prevalent cervical spinal cord injury now in the United States and, in fact, in North America. And it has overtaken the traditional fracture dislocation demographic of cervical spinal cord injuries, and it comes with its own paradigm of presentation as well as complexity of both management and nuances of treatment and so on. So I'd like to welcome my fellow participants from University of Arkansas. I am joined as a moderator by Dr. Victor Police, who joins us. He's attending in the Department of Neurosurgery at the University of Arkansas for Medical Sciences. We'll be joined by a couple of other friends and faculty shortly from UAMS who are hoping to get on this evening. And otherwise, we have Natalie Gooley here, who is our senior and soon-to-be chief resident in the Department of Neurosurgery, and our senior residents, William Coggins and Karar Al-Jabouri, who will present valuable cases that we feel are pertinent for discussion to highlight the complexity and the nuances of both this condition as well as its treatment. So I just want to start off, as I said, and just give a very brief kind of background to central cord syndrome. As I said previously, in the past, cervical spinal cord injury was a disease of the young. And it was a disease where young people were involved in high velocity, high impact mechanism injuries, such as a motor vehicle accident or diving in a pool, or a high impact injury where there was not just significant injury to the spinal cord itself, but also to the structure, whether it involve a fracture or often a fracture facet dislocation. That was what plagued cervical spinal cord injury. What we've seen over the years, and it's very interesting, is that these injuries have greatly decreased in their incidence. And of course, we see them, but their incidence is dropping. And this is a great thing. It's a combination of all of the preventative measures that have gone into, for example, management of motor vehicles and trauma that stems from them, as well as treatment on the scene and reduction and awareness, reduction of these injuries through awareness. What we're now seeing take over as the most prevalent form of cervical spinal cord injury is that of the elderly patient who sustains typically a fall, maybe even a ground level fall, with a hyperextension injury to the neck on a background of cervical spondylosis, which could involve central canal stenosis and so on. So, you know, it is a little bit of an interesting term because it's a misnomer. It has its historical roots in what was felt to be the somatotropic distribution of the funiculi and the spinal cord tracts within the cervical spinal cord, and the distribution of injury sparing the lower extremities, but focusing on the central aspect of the spinal cord where the fibers to the arms and in particular the hands would be located. This has been questioned. And we'll see some of that in the ensuing presentation and discussion. We've covered this topic before, but it is filled with complexities, perhaps some controversy, but most importantly, opportunity for discussion and for better management. So what we'd like to do is commence, instead of a case, commence with a background for this entity. And once that is done, then discuss a couple of illustrative cases which we think will really draw out this most common injury and hopefully raise some discussion with respect to what the optimum management of this is. So I'm going to ask Natalie Gooley, our senior resident, to start the evening, and we will continue our discussions afterwards. Thank you, Natalie.
All right. Thank you very much, Dr. Kazemi, and thank you again for inviting us on for this discussion. So I wanted to give an overview of and I call this a brief review of the literature, because it turns out the body of literature is quite large for this subject. So my talk is entitled Central Cervical Cord Syndrome, Historical and Modern Management. So this is an interesting syndrome which has been managed kind of in a shifting way. So I think the first thing I wanted to go over was, the early history. So it's actually been recognized as a distinct etiology since 1887. It was first kind of brought into neurosurgical literature by Dr. Schneider and his colleagues in 1954 when it was published in the Journal of Neurosurgery. So you can actually see Dr. Snyder here with his colleagues Edgar Kahn and Elizabeth Crosby. So they're working on an anatomical dissection, which he was also famous for. So this is a paper that he published that was a case series of 9 patients that he had described that I pulled this quote from the paper, which I thought was quite interesting. In acute cervical spinal cord injuries, there's a syndrome that suggests central cervical spinal cord involvement. It's characterized by disproportionately more impairment of the upper than the lower extremities, bladder dysfunction, usually urinary retention, and varying degrees of sensory loss below the level of the lesion. The lower extremities tend to recover motor power first, bladder function returns next, and finally strength in the upper extremities reappears. So his first case was so classic for what I think many of us have seen and kind of heard of for central cord syndrome that I thought it was worth going over. So he describes the case of a 65-year-old man who trips on a rug and falls directly on his forehead. He has a brief period of loss of consciousness, after which he wakes up and he's numb and paralyzed in all of his extremities. Over a period of 4 days, he starts to recover and he regains first some degree of motor strength in his legs and much less movement in his arms. So you can see the radiographs on the right here that were taken of this patient. You can see a lateral x-ray of the cervical spine where they have an arrow that's indicating a bony osteophyte that's protruding into the canal at C4-5. This is a myelogram where you can see there's a constriction of the flow of the dye indicating stenosis at C4-5 as well. So about 10 days after this injury, they did multi-level decompressive laminectomies, and they ended up doing intradural work and ligating or sectioning the dentate ligaments at those levels. Unfortunately, which you can see this kind of intraoperative photograph here. Unfortunately, the patient did not do well after surgery and ended up having a decline in his exam. And the authors attribute this likely to the lateral movement of the cord while sectioning the dentate ligaments. They also describe in their paper that they would often do a ventral exploration in order to determine if there was further compression ventrally. So Dr. Schneider and his colleagues proposed a mechanism that included quite a bit of work, or was based predominantly on work that was done by A.R. Taylor. And he was very famous for doing cadaveric studies. So you can see these are some x-rays, myelograms of cadavers that he would put in different anatomical positions. So this is kind of normal anatomical position, flexion, and then at hyperextension, where you can see there's narrowing of the canal. He also had some of the cadavers with extensive spondylitic changes, and he noted that in those there was further scalloping that was ventral as well as dorsal. So of course the dorsal stenosis and kind of scalloping was caused by bulging of the ligamentum flavum, which was what they kind of proposed. And then ventrally, there was this ventral compression caused by the bone spurs and bulging discs at that level. So his colleague went so far as creating a small rubber model of the spinal cord that they ended up putting anatomical drawings onto and drawing a grid, and they actually physically compressed it. And then you can see this is how they studied which parts of the spinal cord would be deformed by this type of lesion. This is how they came to their hypothesis that Dr. Kazemi kind of previously touched on, which is the classical interpretation that the lateral cortical spinal tracts, are, specifically in the somatotopic organization, the cervical ones were more medial, and this was the reason that they thought that that the hands and the arms would be more affected. So Schneider and colleagues concluded that in central cord syndrome without bony involvement, surgery is usually contraindicated. They thought that this, the spontaneous recovery is a natural history of central cord syndrome, and so they felt like that was an indication to, or a contraindication to surgery rather. They also argued that edema is spread longitudinally along the cord, and therefore there's no discrete area that would be able to decompress appropriately. And also in their hands, surgery definitely made the patients worse. So this, for many years from 1954 on into the 70s, was essentially rendered central cord to be a non-surgical disease. So in the this kind of started to shift in the literature in the 80s and 90s, and I've chosen this specific paper because I thought this was a kind of a good demonstrative paper out of Taiwan that was published in Spine in 1997. This was a retrospective review of 114 patients at a single institution. They collected data from 1988 to 1994. There were 28 patients that they treated surgically, 86 were medically managed. They collected a number of different, kind of parameters: age, injury mode, initial presentation, radiographic findings, and timing of recovery, both with and without surgery. So you can see this is a table where they've got every single patient catalog that underwent surgical intervention, and they also have the radiopathology and other demographic data. On average, when they excluded 3 patients who had been operated on 8 months, quite a bit after their injury, they operated on average 10 days from the date of injury. The decision to operate was based on a number of different things: failure to improve, difficulty with their ADLs, worsening neuropathic pain, gross instability, and also symptoms that correlated with the level of injury or compression on their imaging. A majority of their surgeries, you can see, were done anteriorly, with some posteriorly that looked like they probably were indicated for buckling of the ligamentum flavum. Of their medically managed patients, there were actually 11 patients that did have compressive pathology that were still managed non-operatively. These were essentially serving as a control group. So the results of this study, essentially they found that regardless of treatment, self-voiding and their ability to walk in all of the patients was deemed satisfactory about 6 days after their injury. However, in patients, and also in patients that did not have any surgery and they didn't have any active compression, there was a slow, steady improvement of the hand function, which is something that we essentially know about central cord syndrome. So you can see in this table here, the numerical grading for hand strength and the initial scores were quite low for a number of these patients, and about 7 days, 14 days, and then by a month, a lot of these people had regained full hand grip strength. In their surgical group, they found that about 3 days after surgery, patients tended to improve significantly. So you can see this chart here where they have all these numbers here correspond to the numbers of the patients they described in their initial in that initial slide I showed you. And essentially preoperatively, you can see these are grip strength in their hand, quite low. On the day of surgery, some people had improved somewhat, but by postoperative day 2 and then 3 months out, you can see a large number of these people improved significantly with full strength in a lot of the patients. And this was in contrast to that group of 11 patients with compressive pathology that were managed non-operatively. You can see on the initial day here, the scores 7 days out, they had improved somewhat, but essentially there's a plateau between 7 days, a month, and 3 months. So their conclusion was that operation may result in better outcomes in these selected patients with cases with compressive pathology. They hypothesized there was likely a vascular component, also a potential dynamic instability that has kind of an ongoing pincher type mechanism that causes micro injury. And essentially this is when you start to see this shift. So I wanted to kind of illustrate, I found this paper, which I thought really nicely demonstrated the paradigm shift. This is a large narrative kind of type review that was published in the Global Spine Journal in 2019. And what I really liked in this paper was they pull out all of the literature on central cord syndrome, and it kind of catalogs it through the years. And you can kind of see this shift that I described, where in the 1950s, set all the way through the 70s, there's this favoring of conservative treatment as patients likely get worse with surgery, all of those things that I had just spoken about. And then in the 80s, you start to see more publications that are kind of favoring surgery. These patients are having greater functional recovery at discharge, quicker motor recovery with a decreased length of stay, and even improvement of one ASIA impairment scale at 3 months post-op after follow-up. So what's also interesting to note is that even in the 2000s, as you start to have this paradigm shift of, favoring more surgical treatment, you still have some quite large studies that are showing that there's no benefit with surgery. So that kind of indicates this controversial nature of the pathology. So I thought this paper also brought up a number of different things that are kind of just points of interest with central cord, which is that one big problem with this is central cord syndrome does have an inherent potential to improve with or without surgery. That's kind of the natural history of it. The papers reliably, all of these studies kind of reliably show that the extent of recovery is directly related to the initial injury severity or the kind of injury, neurologic baseline that they have after injury. So the question is, that some of these papers bring up is there a potential for quicker recovery than without surgery, which of course, is important. And then maybe a overall magnitude of recovery could be greater. So the conclusion, both conservative and surgical interventions for the central cord syndrome without fracture or dislocation have been demonstrated to result in improved neurologic status. Patients treated with surgery do recover faster and therefore have a shorter length of stay, which is of course important. The longer term follow-up unfortunately has failed to demonstrate a difference in the functional recovery. But nonetheless, patients with mechanical instability or ongoing compression, surgery is the mainstay of treatment. This kind of is the new paradigm now. So we've talked about, okay, now we've shifted from non-surgical to surgical, but what about timing? So this is a study we're all familiar with. This is kind of a landmark study in timing of surgery for any kind of spinal cord injury. The STASCUS trial was published in 2012, a multi-center international prospective cohort study that had 313 patients. They were ranging from 16 to 80 years old. 182 underwent early surgery that was within the first 24 hours, and 131 that were at or after 24 hours. So they found in this multivariate regression analysis that patients who underwent early surgery were more likely to improve at least 2 AIS grades at follow-up. So it was a little bit unclear, how does this relate directly to central cord as a distinct subset of spinal cord injury? So further studies were warranted. In 2022, in JAMA Surgery, this paper was published that specifically looked at early and late surgical decompression for central cord syndrome. So this is a very interesting propensity matched cohort study that included data from 3 very large data sets on spinal cord injury, the NACTIN registry, STASCUS, and the NASCUS registries. So they screened through the patients and found those who had central cord syndrome and underwent surgery. And after their exclusion filter, they had 300 that had kind of complete baseline data. They split into an early and a late surgery category. They did propensity score matching, which were pretty reasonable, and they found 93 in each category that they were able to directly compare. So I pulled this table out because I thought this was the most interesting, and I highlighted what I thought were the salient points here. So overall, in the early surgery cohort, the upper extremity motor strength is what this stands for, was significantly improved in the early surgery group when compared with the late surgery group. That numerically, it's not super impressive, but it was still significant. When they further pulled out those with Asia grade C injury, they found that also the lower extremity motor strength was improved significantly, and their overall strength was. So essentially, I thought this was a really good quotation, which I pulled out. Dr. Okonkwo was invited for a commentary on this paper, and this is a really good quote that I've pulled out. He says, the options are to decompress early or not. Although literature can be cited to defend a delay in surgical decompression, there's not a benefit in doing so. On the other hand, the possible gain to be made from early decompression is too great to ignore clinically. So this really highlights the problem that we always get into as surgeons, which is this kind of cost-benefit analysis, which I think in the case of central cord, the argument is that, there's a lot more to be gained. So the very last thing I wanted to briefly touch on is the medical management side of central cord syndrome, where we start to use MAP parameters. So this is largely based off of two studies that were done in the 90s. This is a study that I pulled out. This is one of them by Dr. Vale. This is out of Alabama. It's a prospective single institution study where essentially they decided a MAP goal somewhat arbitrarily, although it was kind of more of an educated guess. They extrapolated from data on cerebral perfusion pressure after mild to moderate TBI, and they determined the MAP goal greater than 85 was to be used. They used 7 days as their duration. This was based off of the fact that peak swelling after these types of injury is usually 3 to 5 days. And then they included information about whether the patients required pressure support or not. So it did include patients with cervical and thoracic injuries, and essentially I pulled out two of these tables, but really the kind of thing that I thought was most interesting about this was in those with cervical cord injuries that were Asia A, they had, at their 12-month follow-up, I mean, some of these people were, quite improved. Now, this was more of a qualitative study, not really quantitative. They determined that, look, this is feasible, it's safe. They did see improvements, but they had no control group for comparison. But this is essentially, what kind of we were, we base all of our MAP goals off of. So unfortunately, the definitive proof to show that MAP goal efficacy is, or MAP goals are efficacious, continues to elude us. So I pulled out this paper that was published in Neurosurgery Focus in 2017, and this looked at the impact of blood pressure management after spinal cord injury. This was a systematic review of the literature. So they looked at 11 studies, and they found that, this is kind of one of the quotes that I pulled out, which I thought was pretty important to the topic, which is, with regard to optimal MAP, there have been no comparison studies to date, randomized or non-randomized, that compare differences in the outcome with different MAP goals. They also did not find that there are any studies that compare outcomes related to different durations of MAP goals. So this is the kind of table that shows all of the literature that they reviewed. And I did highlight this one because of all of them, you can see that there's only one that actually had a comparison group or a control group. But unfortunately, the control group was so small, it only contained nine patients. So it was not really kind of useful for doing a direct comparison in that way. So MAP goals are something that we can do, but still lots of room for improvement as far as, really kind of proving their efficacy. But this final study that I pulled out, this is kind of newer in the world, in the kind of spinal cord perfusion aspect and medical treatment. So this was published in World Neurosurgery in January of 2020 by a group out of UCSF. And they were essentially doing a feasibility study to look at spinal cord perfusion be optimized using intradural pressure measurements in the same way that we do goal-directed or perfusion-directed therapy for cerebral perfusion pressure and traumatic brain injury. So they had a protocol where they placed lumbar drains in every patient with a spinal cord injury, ASIA A through C, sometimes D, just kind of depending on their discretion. And they used it to optimize the spinal cord perfusion pressure to greater than 65. They did this for 5 days. They had 5 patients. Essentially, this was, like I said, a qualitative study, not really quantitative, but they found that it was feasible and didn't have any kind of increased risk to the patient. So overall, this is the kind of a whirlwind review of the literature on this subject, but hopefully we can kind of talk more about it. And it really highlights the fact that this has continued to be a kind of controversial and very interesting pathology for us to address throughout history.
Thank you very much, Natalie. I think that was an excellent review. You really covered all of the key features of central cord syndrome and some of the historical features, and in so doing, some of the controversy with it starting out as a non-operative condition. We were all taught it was non-operative years ago, and then at some point there was a time limit given. Do you recall that they said that there was a cooling off period, that we would allow central cord patients to cool off for a 6-week period or so. I'm not really even sure where the 6 weeks came from, but some of our senior surgeons may recall that. And now it has really morphed into an active condition that is treated, especially where there is a structural deficit, incredibly urgently for the purpose of saving spinal cord. And Michael Failings, who's done a huge amount of work on this, both through the Staskus trials and other key work throughout many, many years, really refers to the concept that time is spine. And it makes sense where there is something to do with the spinal cord. If it's reduction of impact through reduction of a dislocation or a decompression, or even a stabilization and decompression, this is seen as an important part of the surgical management. I think the jury's out, however, on a few little things, and this will be a rich source of discussion in the cases that we'll have. One is the concept of ultra early surgery, meaning that the patient is literally taken from the trauma bay to the operating room to be treated, to have their either structural deficit corrected or to be decompressed across a region of swollen spinal cord as seen on imaging. What is the value of that? There is great controversy in that respect versus the concept of early. The other is the patient that is deemed to be improving or stable versus one that is not improving or deteriorating. And where is the role of surgery in that patient? And partly the reason I bring this up is from the dreaded phenomenon of the reperfusion injury. We've all had patients that, despite meticulous attention to both the operative technique involved in their decompression and stabilization, together with meticulous attention to intraoperative map parameter goals, the patient wakes up profoundly weak postoperatively, despite their baseline examination. And this is something that we have to acknowledge and we have to think about. The second thing about the MAP goals, as you said, the study that you presented was fantastic. There have been multiple studies in the past that have tried to look at intraspinal pressure, and as a result, spinal cord perfusion pressure as a result of MAP and ISP, intraspinal pressure. What is the magic number? 85, as you mentioned, was a number that was constructed to reflect convenience and probably to reflect something that was achievable. I think much more importantly is avoidance of hypotension than it is to be fixated on one particular numerical goal. 85 may be too high for some patients. It may not be enough. We won't know until we have a better grasp of what the spinal cord perfusion pressure is doing. The problem we have, as you can imagine, is that we need sample size. And for one center to do this, we may have a handful of patients. We're not going to get the powered studies that we need to until we have multiple centers involved in the studies, doing a multi-center trial and getting us powering these studies. Anyway, without further ado, thank you again for that excellent introduction to the entity of central cord syndrome. So I'd like us to—
That was great, Natalie. Really was.
Yeah, it really was awesome. Thank you. For the rest of the panel, if you have anything if you'd like to jump in and add anything before we move on to the cases, please feel free to do so. Otherwise, Dr. Police.
If I can say some comment, I think this map also may, as you said, may not necessarily be exact numbers important, but it's something for anesthesia during surgery also to cling on something. Let's say, okay, watch blood pressure. Otherwise, they may allow patients to dip too far. So if you tell them 85, so at least for something for them to watch. Also, another aspect of, so I agree. So probably as surgeons, we cannot influence spinal cord recovery by itself, but we can give optimal conditions. So as mentioned, right, ongoing compression, instability. I like for my patients to put in a cervical collar. Whatever I'm going to decompress, but meanwhile, if it's ongoing compression, stability, or if spinal cord injury happened, that means there was some moment, hyperflexion, right, or hyperextension, I'm sorry. So putting the brace, to me, it's important. I would like to hear others' opinion. How do you see that? But I always tend to put patients in a brace. And there's another analogy also with, we see with intracerebral hemorrhages, right? From the disease that was non-operative, we saw like we were pessimistic because patients don't get better. And now we see that it's highly surgical disease, and probably earlier you decompress, the results are better, functional recovery.
Yeah, these are patients you're treating non-operatively, you're putting in a brace?
Look, the question becomes, right, so if there is no instability and no ongoing compression, that's an interesting question, right? So are we saying like we're not going to operate ever? If I say I'm not going to operate ever, maybe not to torture the patient in a brace, because what's the value to keep in a brace?
So who are you putting in a brace? I'm just curious.
The ones that I'm planning to operate.
Oh, until you do the surgery.
Yeah, until you do surgery, yeah. And then depends what kind of surgeries you may continue brace, but at least in the time until you intervene.
Yeah, I want to take up your point. I think you're right. I think that we are really, obviously with surgeons, we focus on the surgical aspects of the treatment of this entity, timing, what we do, but the perioperative medical management to avoid a secondary injury is absolutely vital, just as it is in the brain. You avoid a secondary injury, you control parameters in the brain, such as the sodium level, you control the CO2, the PCO2, you control the temperature and so on. There are multiple parameters. With the spinal cord, we don't yet have these guidelines set out for us. And I think that this is the greatest frustration that we face. I think it's a matter of powered studies that get us there. But you're absolutely right, Victor. I think that the medical management is key as well. We have to avoid hypotension. Again, I don't want to focus on the 85. I just want us to prevent, even intraoperatively, for that patient to dip. That's why I think it's important for the anesthesiologist to have a great grip on the arterial pressure. I think it's important for inspiratory volume to be followed up postoperatively in the ICU, to look at a bunch of things, dead spacing, VQ mismatch, and so on. There are multiple medical things that we can manage better in these patients. I'm joined by Dr. Hector Soriano Baron. Hector is just arrived back from CNS. So welcome back, Hector. Hector is our newest colleague. Dr. Soriano Baron, please go ahead.
Thank you very much, Dr. Kazemi. First of all, it's a pleasure. Thank you for your invitation. Sorry I was late. As you can hear, I'm still in the airport. So basically, I just landed from CNS. My flight had some mechanical problem and we couldn't take off. But anyway, so I think that this is a very, very interesting topic for any spine surgeon, because this is one of the most common spinal injuries that we can see, central core syndrome, right? And the management of the central core syndrome starts in the moment of the accident. As you perfectly said, it's not just the hospital. And probably a lot of the things that I'm saying, you already say, and I'm sorry, I apologize because that was my fault because I was late. But the reality is that since the immobilization of the patient, before he gets transferred to the hospital, of course, the way he's resuscitated after the trauma, and then when he gets to the hospital, there are a couple of things that we have not been able to elucidate if they're useful or not. Probably you already talked about steroids. Steroids, we thought we're gonna use them, and then in 2013, the guidelines from the neurosurgery guidelines, they say, oh no, level 1 evidence, do not use steroids. Then 2016, AO Spine says, like, you know what? We should use steroids in the first, it's right in the moment of the accident, the first 8 hours. And then if you see the review that was published by Global Spine in 2019, well, we don't really know. We know that probably are beneficial in the first 8 hours. A lot of the referral centers, like the one we don't get the patients 8 hours from the accident because sometimes they get transferred to a local facility and then to another hospital. And by the time they got to us, it's like 12, 14 hours from the accident. So that is one number thing. Number two, MAP pushes, right? As you perfectly say, 85, 90, it's just a number. There are a lot of studies that show at the beginning that it was very useful. Now there are some studies showing that hypotension actually does not hurt, but we don't really know. We believe that it helps. And I think that the majority of the bulk of the literature that we have shows that it proves that it helps. And 85 is just a number that we can tell everybody to follow, right?
Great.
I believe that the difficult part is who you are gonna operate and when you're gonna operate. And for me, that my take point is that we have 4 things that we need to consider. Is the neck unstable, right? Stable or not stable? If the injury is stable or not. The patient has ongoing compression, yes or no? And the patient is symptomatic from this because a lot of the times the compression was a chronic problem that was just exacerbated by the hyperextension of the injury, right? And lastly, is the patient gonna be safe to go for surgery?
Excellent,
and
thank you so much. Yeah.
The last thing is, so you're gonna do it acutely, hyperacutely, or later on, right? So it's very difficult. So, but anyway, thank you for the invitation.
Hector. Absolutely. Those are really great points. And that segues very nicely actually into the 2 cases that we have. So I may ask our first case, Dr. William Coggins, our resident at UAMS, could you please start with your case?
Yes, so I'm Will Coggins. I'm one of the PGY4s here at UAMS. Thanks again for having us host. So I'll be doing the first case presentation. So our clinical history, this is a 65-year-old gentleman, history of alcohol abuse and a prior stroke, who presented to us with altered mentation and weakness after a ground level fall. He came in as a trauma activation, and from the get-go, his exam was very limited due to his acute intoxication. And his initial exam is a GCS-12, and he had left hemiparesis more so than his right side. And he was so altered, he was not able to follow any kind of commands, and any segmental exam was not able to be obtained. Of course, we had some imaging from the onset. The CT of his cervical spine demonstrated findings consistent with DISH and a vertical or AT split fracture of C4. CT of the head showed his prior frontotemporal stroke in the left hemisphere and a former craniotomy, although we didn't have a lot of information about this gentleman. So we didn't have much background history. Our initial plan was admit him to the surgical ICU, Q1 hour neurochecks, strict cervical spine precautions with an Aspen collar, MAP goals, as we've discussed. He was put on CWAP protocol for his alcohol abuse, and then an MRI of the cervical spine. So our initial imaging studies, on the left, we have just plain film CTs of the head. You can see the encephalomylation, his left temporal lobe and his left frontal lobe. And it's, we noted initially that he has encephalomylation as SMA region as precentral gyrus. So we were expecting that he probably would have some baseline right-sided weakness. On the right, we have a sagittal picture, CT of the cervical spine. You can see the C4 split fracture. And then I've put stars to kind of correlate with this coronal shot, where you see he has a pretty prominent anterior bridging osteophyte from C4 to 5, which we felt probably indicated this was maybe a little more stable than it could have been. And then just another axial cut showing the fracture. This is the MRI of his cervical spine that was done overnight. On the left, we have 2 more sagittal views, STIR and then T2 respectively. You can note that at C3-4, the ALL is disrupted with some STIR signal there. And then posterior to that, within the cord at the C3-4 disc space, you can see there is STIR hyperintensity and T2 hyperintensity. And then here's some coronal views just redemonstrating that. And then finally, in bottom right, I have an axial view at the C3-4 disc space. This is just showing his chronic disc protrusion at the level. And we felt it was chronic since there was no STIR signal within the disc space. We felt pretty confident and hadn't been disrupted in the fall. And then also you can just see he has pretty significant compression at baseline. His canal diameter was stenotic to 7 millimeters at that level. So post-injury day 1, we were able to examine him after he had sobered up. His Aspen was in place. You can see in his upper extremities, he's profoundly weak distally compared to his proximal strength in his delts, tris, and bis. And then the right side was worse than the left, particularly with his finger intrinsics. His lower extremities were full strength, except for some subtle functional weakness in his right leg that we expected with the history of his stroke. He had pretty profound allodynia in his shoulders, but otherwise his sensation was intact to light touch. His reflexes were non-pathological. He didn't exhibit a Hoffman sign or any clonus. So at this point, we labeled him an Asia D. Our assessment at plant this time, a 65-year-old male, history of alcohol abuse, stroke, and dish, presenting after fall with an A2C4 fracture and C3-4 ALL disruption with central cord syndrome. So our plan adjusted. We continued to maintain his MAP parameters. He was not needing any kind of IV or PO pressor support at this time. Gabapentin was given to treat his allodynia, and his exam improved. And on post-injury day 3, he was 2 out of 5 in his distal right uppers, and left upper was 4 out of 5 proximally, 3 out of 5 distally. So this time we wanted to kind of pause and see if the panel had any thoughts on his care up to this juncture.
Right. Nice case. Thank you, Will. Illustrating, again, this kind of picture, albeit in a slightly younger person. Again, probably mechanism of injury, a hyperextension injury of some sort, clearly leading to signal change within the cord and likely central cord, given the involvement of the upper extremities. So I wanted to ask my esteemed panel whether they had any particular thoughts, just to kind of, elucidate aspects of management, particularly given that there was improvement within the first few days in this patient. Any thoughts? Would anyone have decided to jump in and operate earlier? Yes, Dr. Chapman, we're joined by you. This is fantastic.
So sorry, guys, I was late in the OR. I think this is a great case, and I actually have the same patient upstairs in the ICU, and we're going to take him to the OR tomorrow for a posterior C2 to T2 fusion with wide decompression from under C2 down to T1. The reasons we want the cord to fall away, we waited for 72 hours
Jens, sorry, we just lost you.
Sorry, my bad. We waited basically until tomorrow, and we're gonna do tomorrow post primarily, and do a wide decompression that the cord falls back, and we'll keep his maps above 85 until at least 24 hours afterwards. So I would fuse this man posterior only. I would not worry about, and in fact, I would vote against going anteriorly, given this OALL, OPLL dish kind of a disease process. It's actually a very ugly one to treat from the front. Those are my thoughts.
Did you say C2 to T2?
Yep, coast to coast.
Wow.
The general
But the
trend.
pathologies at C3-4. Well,
the general trend.
So
Yeah,
why
the
would you
general
do
trend that
it?
I see in cord injuries now, severe cord injuries, is if we go posteriorly to do a multi-level decompression and decompress above and below the lesion site to let the cord fall away and improve cord perfusion through that. So the number of like the Maryland group, they've actually presented here, and in our annual spinal cord injury symposium, we'll have the new one this December. We'll again have a number of thought depending this, but I've been impressed with how the general trend is now to be very aggressive with posterior multi-level fixations that the little cord falls away. There's nothing in the front anymore. Those are my thoughts.
But Jens,
I'll quote one of our previous colleagues from Parkland, Mad Brad, and talk about the personality of the fracture. And the pathology is anterior. It's an ALL disruption. There's anterior compression at C3-4. I mean, would anybody go like, and then again, save some levels, would anybody just go anteriorly, either C3-4, although with a fracture C4, say 3 to 5 anteriorly, because the pathology is anterior?
Yeah, but Scott, it's a stable injury. He's got an unusual coronal fracture through the body that's reduced. And here's a guy who's got other issues with a prior craniotomy, with a stroke, with recovering alcoholism. So, and he's getting better. So why is this a guy that you need to operate on at all? And Jens, why so extensive?
So I'm assuming that the patient's plateaued. So yes, I would let him continue to get better before I would intervene surgically. And if he plateaued with an incomplete injury, then I think you're obligated to do something surgical. But I think his decompression's anteriorly. He's got a ligamentous injury anteriorly and basically a disc at C3-4 causing cord compression. I think it's anterior pathology.
All right. So interesting. I think this is the beauty of this discussion, right? We have two very rational thought processes here with respect to the injury. What I would be keen to know as a subset of the study done by Dr. Failings et al. When they combined the Staskus, the North American controlled trial group patients in Staskus 3. Because they teased out through propensity matching, as you heard, the central cord patients, and they demonstrated that these patients did better earlier than later. My question is, did the patients that uniformly did better, were they the ones that were already improving compared to the patients that were either stable or demonstrated deterioration in their findings? And then the question then could be, well, what time period do you need to determine that, right? Because you miss the boat if you wait to find out. I definitely know John Hurlburt and others make the argument that if the patient is stable to improving, they would either wait or they would not do surgery at all. I definitely see the rationality in going wide, because you allow the spinal cord to come back. The only question I have for Dr. Chapman, and we've seen it, maybe you have too, Jens, is the reperfusion nightmare injury, where you decompress the spinal cord across multiple segments, and the patient wakes up significantly weaker post-op, and a post-op MRI, that signal change that you saw over a few levels is now widespread. Could you comment a little bit on that?
So reperfusion injury, you mentioned several times, is one of our nightmares. And obviously technique matters and maps matter. And I'm a pro-steroid person, and the technique does matter in terms of having and how you do it the hard way, and you can't have too much additional blood loss. And we still don't know when the worst time period for a second perfusion injury is, but it's probably within the first 24 hours if there's a secondary hypotension. At this point in time, with the patient 3 days out or so with some improvement trend, I don't think this is a very big problem, again, unless there's a surgical mishap. And again, doing a no kerosene, basically drills and gentle elevation, and telling the anesthesiologist to have the pressure high, and obviously checking your motors during that whole time. Those are the key things. So while always a theoretical concern, it's not a practical one. In terms of the this particular patient, my worry is he has fractures, so this is not an entirely stable neck. And again, I've not found these C2 to T2 fusions to be that particularly big. It sounds big, and we've just become much more efficient probably in doing these pretty safely. This is not the mega ordeal it once was. It still has a higher infection risk than anterior surgery without a question, but the morbidity of a patient going on an anterior exploration, this OALL, OPLL dish disaster would be problematic. And again, I don't even know how to fully describe that coronal fracture. So my clear vote be is if surgery, if medically cleared, and his liver enzymes is okay, I'd go posteriorly, and I'd go again coast to coast.
All right, thank you very much. We have time for one more case. Dr. Al-Jabouri.
What did you do? What did you do?
So go ahead, Will. I'm sorry, go ahead and finish off the presentation.
Yes. So we went posteriorly. His somatosensory and motor evoked potentials remained stable throughout the case. We placed C3 through 5 articular or lateral mass screws, and then trough laminectomies at 3-4, and then he was returned to the ICU for blood pressure monitoring. And then post-operative course, he did have immediate resolution of his allodynia after surgery, and he steadily regained strength. At the time of discharge, he was 4 out of 5 in his bilateral uppers, except for some slight weakness in his right hand. And he was discharged to rehab on post-op day 4. And by 5-month follow-up, he was full strength.
So Jens, what do you think about that? That wasn't coast to coast, as you say.
Again, I didn't look at all the MRI scan images, but I've not regretted. And I feel in good company with Jim Harrop and even Hurlburt and others in doing multi-level posted decompressions for serious cord injuries. So congratulations to my colleagues in Little Rock.
So I just want to chime in that I think it's really interesting, Dr. Chapman, because this is the exact argument that Dr. Schneider had said back in the 1950s when he described the fact that you'd have to really, to adequately decompress, you have, because the edema, extends so significantly past that kind of point where the injury occurs, that you would have to do these kind of multi-level laminectomies. So I think that there's, they're just kind of in your defense, and not that you need my defense, but I think it's a very, that's part of the argument that's been kind of ongoing. So
you know that Dr. Chapman is a student of history, and I know that went into his decision-making paradigm.
I just want to say you have, number one, you have fans in Arkansas, Jens, always. And number two, Dr. Schneider's initial operations involved intradural exploration and division of the dentate ligament for rotation of the cord, which I'm sure you won't be doing. So, yeah.
Wait. So this is something, again, as we now know, which our, for instance, cardiothoracic surgeons are doing pretty routinely when they do thoracic aneurysms. They actually drain that. So our neurosurgery fellows, our surgery fellows have to go over there and do intradural drains for them. So decreasing CSF pressure does increase cord perfusion. I don't know anybody who voluntarily does this so far in North America, but Brian Kwan in Vancouver, who's also a multi-level posted decompressor now with serious cord injuries, they do think that this is not a minor deal. So stay tuned. The intradural decompression of Dr. Schneider's vision may come. I'm really appreciative of the support also. Thank you.
Of course, as always.
Can I see a real quick anecdote? Last week I did my
Victor, we have one case left, and
okay. If we have time, I'll tell
yes,
us.
if we have time. So please go ahead, Dr. Al-Jabouri. Last case, last presentation. Go ahead.
Thank you, Dr. Kazemi. Can you guys see my presentation?
You've started screen sharing. Go ahead. Progress on to the next slide.
All right, so this patient is a 37-year-old male who presented as a polytrauma after a motorcycle accident, and the patient had a court signal T2 from C4 to 6, and also had PLC disruption as well as a C5-6 disc bulge. And the patient also had a left C6-7 facet widening with sterile signal. Initially, the patient was not examinable because he was hemodynamically unstable, and he also had a TBI, and he had multifocal injuries that were serious, including soft tissue and orthopedic injuries such as a right open femoral fracture. And so I held the sedation, and then based on the exam at that time, the patient's injury was consistent with an AJC. And so the initial plan was that we kept the patient in an Aspen collar, and then cervical spine precautions as well as MAP parameters as we discussed earlier. These are the pictures, and on the CT scan, we can see the widening of the facet as well as the stir signal right next to it. And then the MRI of the cervical spine, we can see the T2 hyperintensity spanning C4, 5, and 6. And the TBI, we can see that he had a diffuse cerebral edema as well as dependent hemorrhage in the right occipital horn. And so at this point, I would like to know what you guys think as far as the next step.
Right. And in the interest of time, if someone just wants to shout out whether they'd go front, back, if they would even operate, that would be great. Jens, do you have any comments on this one? Is this another C2 to T2?
ACDF, thank you. ACDF.
ACDF. Okay, great. ACDF.
Bicortical screws, bicortical locking screws, ACDF.
Okay.
Even early. Make sure you hyperlordose. Make sure you don't overextend the patient.
Okay, very good. Excellent. All right, I think we'll just proceed. Go ahead, Karar.
That's exactly what we did. And so we did a C5 to 7 ACDF 24 hours after presentation. The CT scan is on the right, as we can see. And this is the patient's post-op exam when he was examinable on the left side. And this is right next to it, the most recent exam from a couple of days ago. And he had significant improvement, especially in the biceps, triceps, as well as the wrist extensors and flexors. He had good strength in the left lower extremity initially, but also his right lower extremity improved distally, dorsiflexion and plantar flexion. So he is still in the hospital, and he's still making recovery, and he's going to acute rehab. And then we kept the MAP parameters for 5 days after surgery.
All right. Well, thank you very much. Does anyone want to chime in just before we close? I know I want to be respectful to everybody's time. It's almost 8 p.m. Central Time here.
The only detail I'd say, this is beautifully done, but I would insist on bicortical screw staying with, again, another hero of spine trauma, both from Caspar and having rigid locking screws, so no variable angle screws.
Great. Thank you so much, Dr.
Guys,
Chairman.
let's have Dr. Ziegler and Dr. Geyer and Dr. Blumenthal send us off. Look at this, October 13, 14, motion preservation course, an absolute all-star course. So Jack, Rick, Scott, who wants to take us out?
Yeah, I just thought I want to thank the guys from Arkansas. Another wonderful presentation and great topic. It's evolving treatment in during our careers, which is kind of neat. Beautifully explained historically and some great cases. So, thank you guys. You are all stars. We appreciate your fraternity.
Thank you.
Yes.
Thank you.
And once again, things are never black and white in medicine, especially spine, but at least you gave good justification for what we do. So again, Natalie did a great summary. That was terrific. And your other
Absolutely.
resident as well. Thank you,
Thank you
Noojan.
very much.